Welcome to this session on research methods. We're going to examine one paper in detail. Many of the issues we have looked at in the research methods are highlighted in this paper. For example, how to determine if there are risks associated with taking a particular medicine. This is the paper we're going to look at. It's by Walker and colleagues, and it's called Cardiac Mortality in Users of Olmesartan, Other Angiotensin-Receptor Blockers, and Angiotensin-Converting Enzyme Inhibitors, and it was published in the journal Pharmacoepidemiology and Drug Safety in 2014. So first of all, what is the paper about? The abstract states that clinical trials of olmesartan for the prevention of progression of renal disease in patients with diabetes showed renal protection but an unexpected imbalance in cardiac deaths. The US Food and Drug Administration requested from the manufacturer a cohort study of olmesartan compared to other drugs shown here. So the first question is, why did they want a cohort study? We will look at this in a later slide. Moving on to the introduction. The goal of the present study was to meet this requirement and to provide scientific evidence on the incidence of cardiac mortality and total mortality in users of olmesartan and the other drugs. So why did they want to look at incidence? Again, we will look at this later. First of all, what are ARBs? ARBs lower your blood pressure by blocking the actions of angiotensin II. This allows your blood vessels to relax and widen, making it easier for blood to flow through. It also reduces the amount of water your body retains, which lowers your blood pressure. Angiotensin-receptor blockers can be useful for people who have diabetes or kidney disease as well as high blood pressure. This is because there is some evidence to show that they can protect your kidneys. So who might be given an ARB? Many people who have high blood pressure will need to take one or more medicines to control it. ARBs are a popular first choice medicine for high blood pressure. They work in roughly the same way as another type of blood pressure medicine called ACE inhibitors. Some people are not able to take ACE inhibitors because of side effects. It should work as well as an ACE inhibitor without causing side effects. The previous slide mentioned ACE inhibitors. As already mentioned, most people who have high blood pressure will need to take one or more medicines to control it. ACE inhibitors are a popular first choice medicine for high blood pressure. ACE inhibitors can be useful for people who have diabetes or kidney disease, as well as high blood pressure. This study is going to focus on one of the ARBs, olmesartan. As we have seen, high blood pressure can be controlled with medicines such as olmesartan. The patient's doctor will probably also recommend that the patient make changes in his or her lifestyle to help lower the blood pressure, for example, losing weight, giving up smoking, reducing the amount of alcohol consumed, and reducing the amount of salt in the diet. The doctor may also recommend the patient to take regular exercise such as walking or swimming. The effect of exercise interventions remains understudied, especially among hypertensive population. One study notes modest but consistent reductions in blood pressure in many exercise interventions across all populations, but individuals receiving medications generally achieve greater reductions than those following structured exercise regimes. So olmesartan reduces blood pressure. In placebo-controlled studies, administration of the tablets resulted in reductions in mean systolic and diastolic blood pressures by the amounts shown here. The antihypertensive effects of olmesartan was similar irrespective of age, gender, or diabetes status. This slide shows commonly reported adverse reactions and what to do if they are experienced. The most commonly reported adverse reactions during treatment are headache, dizziness, and fatigue, but the prevalence of these is all fairly low. The most commonly reported one, headache, is around 3% of patients. We're going back to the abstract, this time looking at the methods section. The methods section states that a retrospective cohort study was conducted with the cooperation of a US health insurer. Subject entry and follow-up ran from 2002 to 2009. It goes on to say that in propensity matched cohorts, the primary analysis considered continuous current users. Endpoints were sudden cardiac death and all-cause mortality. So we will look at these underlying concepts in later slides. So we mentioned in this paper that we're going to be looking at a cohort study. So what is exactly a cohort study, and how does it differ from another common study design, namely case control studies? This slide looks at this. So a cohort study is a study design where one or more samples, called cohorts, are followed prospectively and subsequent status evaluations with respect to a disease or an outcome are conducted to determine which initial patient characteristics are associated with it. A case control study is a study that compares patients who have an outcome of interest with patients who do not have that outcome. These are the controls, and it looks backwards retrospectively to compare how frequently the exposure to a risk factor is present in each group to determine the relationship between the risk factor and disease. Cohort studies provide the best information about the cause of a disease because you are following people from their exposure to some risk factor to the occurrence of the disease later on. With data from cohort studies, you can calculate cumulative incidences, that is, new cases, which are the most direct measure of the risk of developing a disease. Cohort studies also demonstrate the direction of causality. An added advantage is that you could examine a range of outcomes. However, cohort studies are major undertakings. They can require long periods of follow-up, since the disease may occur a long time after the exposure. Let's just review the two types of studies. In this slide we can see the two types of studies. We see the cohort study and we see the case control study. In the cohort study, we examine a group of people who are exposed to some risk factor, such as taking a medicine, and we compare them to those who are not taking the medicine or another drug, and we follow them forward to the outcome. In contrast, in the case control study, we start with the outcome and we look back to see whether they've been exposed to the risk factor. Here is an example of a cohort study, and it's called Adherence to a Mediterranean Diet is Associated with Lower Incidence of Frailty, a longitudinal cohort study. Basically, they looked at low or high adherence to a Mediterranean diet and whether this was associated with the later development of frailty. And they found that participants with the highest Mediterranean diet scores were found to have a significant reduction in incident frailty. And here is an example of a case control study. This time the study started with the outcome, infants who had persistent pulmonary hypertension, and they looked back to maternal exposure to SSRIs, which are antidepressant drugs. The study supported an association between the maternal use of SSRIs in late pregnancy and persistent pulmonary hypertension in the infants. Let's go back to the abstract again and read a little more from it. It says that statistical estimation was based on proportional hazards analysis with 95% confidence intervals, and that power calculations had shown that 25 olmesartan initiators would be required to detect relative risks of sudden cardiac death of twofold or greater. Again, these underlying concepts will be looked at in later slides. Something that's important to consider in the paper is the occurrence of the outcome. What is the baseline rate of sudden cardiac death? Basically, is it something rare or is it something common? This will help us to understand the study. From other literature, we find that the overall incidence of sudden cardiac death, based on extrapolation of data from the United States, is approximately 1 in 1,000 adults over the age of 35 years. Let's look at the abstract again, this time the results. The results tells us how many initiators there were of olmesartans and how these were matched to users of other drugs. It tells us about the average follow-up time and also tells us about the risk of the outcomes in the different drug groups. And finally, it tells us about the risk for a subgroup who were prior users of hypoglycemic agents. We will look at the underlying terms in more detail later. Just to look at one point in this slide, which is the initiators. Why is it important to look at initiators of a drug? That is, people who haven't used them before. This is because the results could be confounded by prior use of these drugs. So that's why it's important to look at people who have begun to use the drug during the study period. The background to this study was 2 randomized trials that were intended to address olmesartan's ability to prevent or delay the progression of renal disease in patients with diabetes that showed unexpected elevations of cardiovascular mortality in comparison to placebo. So here we have a drug that's supposed to reduce high blood pressure that was found to increase cardiovascular mortality. Note, as we saw earlier, that the study includes a hypoglycemic subgroup. The first RCT was the roadmap study. The full title is shown here. In the roadmap study, there was a rough equality of combined cardiovascular endpoints between olmesartan and placebo. However, there was a notable imbalance in cardiovascular mortality. So there was more mortality in the olmesartan group compared to placebo in the roadmap study. The second study was the Orient study, full title shown here. And like the roadmap study, cardiovascular mortality considered in isolation was higher in the olmesartan group compared to the placebo group. So aware of the findings of roadmap and Orient, the US Food and Drugs Administration requested that the manufacturer of olmesartan conduct an epidemiological study to evaluate the comparative incidence of sudden cardiac death, in-hospital fatal myocardial infarction and total mortalities in olmesartan users compared to the users of ARBs and ACE inhibitors. So why did they want to conduct an epidemiological study rather than another randomized control study? Perhaps it was to see if the effect found in the randomized control studies was replicated in the real world rather than a clinical trial. This slide considers the pros and cons of randomized controlled trials versus observational studies. While randomized controlled trials are considered to provide the most robust evidence of the efficacy of therapeutic options, they are affected by limitations that may not reflect how the drug of interest will perform in real life. Moreover, relatively few RCTs are designed using an alternative therapeutic strategy as a comparator, which limits the utility of the resulting data in establishing recommendations for treatment choices. So observational studies may complement RCTs in comparative effectiveness research. This article documents situations in the field of healthcare intervention assessment where observational studies are needed because randomized controlled trials are either unnecessary, inappropriate, impossible, or inadequate. Other papers explore other aspects of this debate, for example, whether observational studies, either case control or cohorts, systematically overestimate the magnitude of treatment effects. Looking at the method section now, it says that the original protocol, as implemented, had as its primary analysis a comparison of olmesartan initiators to initiators of the other drug classes that we've talked about. Secondary analysis included, first of all, a subgroup of persons with prior use of hypoglycemic agents, remember the two RCTs that we looked at, and a comparison with ARB initiators among persons with prior ACE inhibitor use. After seeing the RCT study results, which included a non-significant elevation in risk of about twofold among olmesartan users in the primary cohort among people with prior use of hypoglycemic agents, the FDA requested additional subgroup analysis in persons with prior hypoglycemic use and prior use of ACE inhibitors, persons whom the primary cohort had omitted. The restriction of the initial analysis to people without prior use of ACE inhibitors had the effect of focusing on a population of treatment initiators who may have been substantially healthier than those with prior ACE inhibitor use, and we will look at this later.